afternoon, everyone, and thank you for joining me today for our webinar on FHO optimization and outside use management strategies. My name is Josh, and I see we do have a couple of new people on the webinar today, so that's great. Thank you very much for joining us. I am one of the senior healthcare consultants here at Cirrus Consulting Group, and just for your information, this webinar will be recorded, so if you have to leave early or if one of your colleagues would like to see a copy of it, we're more than happy to send that off. And if you do have any questions, I ask that you please write them down and send me an email at the end of the presentation. My email address and phone number will be provided, so you can contact me if you do have any questions and would like to discuss your particular practice in further detail. So with that, let's go ahead and get started. So for those, again, that are new, let's give you a little bit of a background about Cirrus. We're headquartered in Toronto, founded back in 1994. We have two main components to our companies. One is healthcare office lease negotiations, which we do across North America for both doctors and dentists. And then what we're going to be speaking about today is our healthcare consulting division, which provides billing support and operational consulting for physicians both on an individual and group level. So just some quick facts. Family physicians are better compensated in Ontario than anywhere else in Canada, largely in part to the FHO billing model, which again, most of you know is much more lucrative than working fee-for-service or even in the family health group. More than 75% of physicians say their pay does not align with the care they deliver. Now, what does that mean? It means that they're providing the service, and most physicians are providing extensive comprehensive care, but not necessarily getting paid appropriately for it. So where we come in is to help make sure that all of your billings are going through that need to go, and if anything does get rejected, then we're able to adjust that with you and make sure that you are able to get those billings paid for appropriately. Access bonus, again, most physicians think that they can never be positive if they're negative, but in fact we've worked with many groups that started with us being very negative and are now very positive and on a continuous basis. So there definitely is a change to be made there, and again, that's something that the ministry is looking at quite closely, so something to keep in mind. And Ontario physicians are not necessarily strategic in how they're getting paid. So the FHO model can be very confusing. There's a lot of, codes in and out of basket, and, there's a lot of moving parts that really need to be strategically looked at on a regular basis, and most physicians do not have the time or the energy to do that, so that's where we come in to help those physicians better manage their practice. So the purpose of today's program is to guide you through the FHO income streams, give you a much clearer picture of what it means to be part of the FHO, and just give you a better understanding of where your income is coming from. Now, a lot of you are going to say, oh yeah, I know where I'm getting paid, but most of you probably do not look at your RAs on a regular basis, whether you're physicians or staff or anything like that, but you just don't necessarily look or understand where everything is coming from. And it's very important to know which income streams are paying you and what they're paying you. So the FHO income streams, how are you paid exactly? So the Family Health Organization is a payment model. So we're looking at physicians getting paid a monthly payment for every patient they have rostered. Now, you might see the patient, you might not, but you're still getting that payment every month. So rather than being compensated on volume, so in the fee-for-service world where you're looking to see as many patients as you can throughout the day, in the FHO world, you want to only bring back those that are medically necessary for complex and preventative care. The bottom line difference is throughput versus access. Again, no longer are we looking to see as many patients as we can during the day, but rather see those that are medically necessary. And we always get the question, well, I'm working 7 days a week now, can I still work 7 days a week? Sure, no problem. You can work 7 days a week, but you don't have to anymore. Now we're going to start to pick and choose how we schedule our visits and make sure that we're seeing those that really do need to come into the office, not the ones for the prescription renewals that don't need to have a follow-up, those that have results that can be told over the phone. We want those that are really medically necessary and urgent to come into the office. So a little bit of an illustrative breakdown of the FHO income stream. So you have your capitation, which is your roster, your fee-for-service billing, so that's how many patients you're seeing, what you're billing every time they come into the office. Your access bonus, based on the level of access you're providing and how little outside use is being incurred by your patients. Shadow billing is your 15% based on your in-basket codes for rostered patients, your preventative care bonus, and your special premiums. And we'll get into a little bit more detail on all of these. So a little bit more about capitation payments. On average, you're going to get about $200 per year per patient. So if you have a 1,500 patient roster and you have an even distribution of patients across each age category and sex, roughly $300,000 a year is going to be coming from your capitation. Again, that's going to fluctuate based on the age and sex of the patient. So if you have a little bit of an older practice, you might get a little bit more. If you have a little bit of a younger practice, you might get a little bit less. And what that covers is the 126 fee codes that are considered in-basket. So that's your A7s, some of your counseling codes, the standard care that you're going to be providing to those patients. All other codes are going to be considered out of basket. So anything else that you're seeing for a roster patient, you're going to get paid full fee for service. And you can see on the right side there the breakdown of your base rate payment versus your comprehensive care. Now, those who have come from the FIG will know that the comprehensive care payment is the smaller of the two, and that's what you get when you're in the FIG model or in the CCM. And then when you switch to the FHO model, you include that base rate payment, which is a lot higher than the comprehensive care, obviously. So here's an illustrative breakdown again of the payment scale for your patients within the FHO model. On the left side, you have the dollar value per year. On the bottom, you have your age categories. So from 0 all the way up to 99, you see that babies are worth just under $200, then they dip down, and then for females, it drives up again around the 14, 15 years of age, and for males, early 30s is when you start to see a tremendous value pick up on those patients. So again, as patients get older, you earn more from them because they're going to demand more care. So a little bit about roster management, and this is a question that we get all the time. You know, what is the right size roster for me? And unfortunately, there is no right answer right away. You really have to determine and find that balance, as you can see, between roster size and access for patients. Now, some physicians are going to be able to have 2,000 patients on their roster and work 3 days a week and still manage their outside use and see all the patients that need to be seen, whereas someone might be able to only cover that with 1,000 patients. But again, every physician is different, so we're going to work with you to find that right roster composition. Providing that access for patients, again, is really independent for each physician. Some physicians may be able to see more patients throughout the day and week, some physicians a little bit less. So building the right roster that meets your financial goals is very important. And again, making sure you have the right patients rostered. So looking at your EMR versus your Ministry of Health roster to make sure that it aligns. And again, that's something that we help with as well. So how do you roster a patient? So right now, Q200 is what triggers rostering of the patient. You see a new patient, you want to roster them, great. You bill a Q200 on your visit, and you submit that to the ministry, and that triggers the rostering. There are a few extra bonuses, unattached patients, new patients, FOBT if they're positive, and a complex vulnerable from Healthcare Connect. So those are the few extra bonuses that are available, but they don't pertain to everyone, so we're not going to talk too much about that. And then if you have any long-term care patients, keep in mind the Q202 is what needs to be billed in order to roster those patients. So now you're going to ask, what's the financial impact of rostering? So as little as 25 additional patients will impact your capitation on a yearly basis by about $5,000, again, depending on the age-sex breakdown of those patients. All the way up to 200 patients, $40,000 a year. Now some of you may be thinking, oh, 200 patients, that's so many. Yes, for some people it is, but if you have 1,000 patients and you're upping it to 1,200, those 200 patients, you might not see them that frequently. If you're taking the right patients and you're seeing that you have the right practice style, it's not going to be a huge increase in time served for those patients. So it really is good to have that right balance, again, finding the right roster size. And as little as 200 patients can increase your income on a yearly basis by $40,000, which is quite a bit. So a little bit more about fee-for-service billings. So in fee-for-service billings, you can really look at it in two perspectives, as you can see at the top, enrolled patients and non-enrolled patients. So in the fee-for-service world, or even in the FIG world, you're basically seeing everyone fee-for-service, and you're just billing whatever you're billing, and you're getting paid when you see them. In the FHO world, enrolled patients, as I said earlier, you get your capitation for in-basket services. Anything that's out of basket, so not one of the 126, you get the full value for. When you're seeing non-enrolled patients, however, you're getting the full value no matter whether it's an in-basket or out-of-basket service. However, you have to keep in mind that after the first year of being in the FHO, there is a hard cap on the in-basket services that you can provide to non-rostered patients. So for example, A007, there's a limit on how many codes you can bill, or sorry, the dollar value throughout the year that you can bill for those patients. It's about $60,000 per year per physician, and it is pooled together at the group level. So if you have 10 physicians, that's $600,000 that you're allowed to bill for in-basket services to non-roster patients. If one physician goes over their $60,000 limit and one physician is under by the same amount, they'll even out, and you don't have to worry about that. But it is something to keep in mind. We have had a few instances recently with a group where they moved into their second year of the FHO, and all of a sudden they realized that they were running their walk-in clinic and they were seeing too many patients, and now they owe the money back to the ministry. So it does happen. So it's something very something to keep in the forefront of your mind. So out-of-basket services. So here's our full practice billing guide, or what we like to call our cheat sheet that we provide to all our clients, whereby it's a handy guide to keep around when doing your billings, just to see what's going on. What codes can I bill? Are there any out-of-basket codes for this service, for this visit that I've had, or am I just going to bill an A7 again? Some of the key areas, obviously, are diabetes management, smoking cessation, and after-hours billing. All three of those areas are out of basket, and they do provide a good amount of income if you do have those patients and you are providing those services. So a little bit more about diabetes. K030, Q040, those are the two diabetic codes. Recently, they have switched it. It used to be you could bill the Q040 at any time during the year because you are providing the flow sheet of information for your diabetic care. Now you have to bill it after 3 visits. So you're going to schedule 3 K030 diabetic management visits. After the third one, you're going to wait a day, maybe a week, and you're going to bill the Q040. If you bill the Q040 prior to 3 visits of the K030, it will get rejected. And we're seeing that more and more now because people are not realizing that they have to have the 3 visits of the K030. But if you do have those patients and you are maximizing the visits, as you can see, the illustration, just on the diabetic care alone is $26,000 to $30,000 on our average roster size. So that's quite a bit of money. And again, those are out-of-basket fee codes, so you're getting the full value. Now a little bit about smoking. So the E079 is billable once per year, and that's in addition to an A7. So you have someone coming in for a chest cold, and you talk about quitting smoking. So you're going to bill the E079 on that first visit. Then you're going to book 2 subsequent visits, K039, Q042 together, and that's going to provide you with about $100 a year per patient. So if you're billing those basically 3 visits, your first one with the E079 and 2 follow-ups, you're going to get about $100 per year for that, for just talking about smoking. And again, on an average roster size, give or take about $15,000 in additional income. So let's talk now a little bit about your net access bonus. So patient management, outside use, all these areas come into play when talking about outside use and managing your access bonus. So accessibility is a huge term that we're going to be speaking about a lot. Managing your roster is all about providing accessibility. And I spoke about earlier where you have to manage your access to patients with your roster size. So outside use is a daytime access issue. Ensuring same-day appointments are available, extremely important. Making sure that, on Monday morning, Tuesday morning, when someone calls in and says, my daughter got sick over the weekend, I need to bring her in, that you actually have a spot available for them to come in. And it's not, oh, maybe we can see you later in the week. No, you have to have them be able to come in as soon as possible. Assessing the needs of your patients. Your patients' requirements and needs and desires are going to change all the time. So changing your schedule all the time might be of value. And again, I'm not saying drastically change, but leaving a few extra spots open on certain days of the week, certain times of the year is very important. During flu season, maybe a few more. In the summer, people are on vacation, maybe a few less. And it really is something that needs to be looked at on a regular basis. And that's something that we do provide with our outside use management analysis to help give you guys a better idea of when your patients are seeking care outside of the clinic and what you can do to sort of mitigate that and bring those patients back into the clinic. Collecting emails, again, with technology, very, very easy to send out information to your patients on changes to your schedule, changes to the office hours, any other important issues that are going on within the clinic that need to be addressed and given and have that information given to the patients. Email is the easiest way of doing that. And with almost everyone nowadays having access on their phones or especially at home, it's an easy way and a no-brainer. Again, extra office hours, more open spots on busier days. If you find that Wednesdays happens to be a really busy day for you, don't schedule physicals on that day. Leave more spots open. Schedule shorter visits for patients. And if Fridays happen to be a very quiet day, great. Schedule all your physicals on that day. Bottom line, patients need access, and adjusting your schedule accordingly is very important. So how do we manage outside use? What are some of the best practices? It's very hard to control patient behavior, but learning their behavior, learning what they're doing so you can adjust and meet their demands without drastically changing your schedule. Educating the patients, very important. Letting them know the impact of seeking care outside of the FHO. Lack of continuity of care. You don't know what's going on when they go to the walk-in clinic. The doctor there is going to run a bunch of tests. They're going to give you some prescriptions, perhaps. All of a sudden, you come back to your doctor and you're giving them something else. There's a huge issue there. So lack of continuity of care, making sure that they're aware that if they come to see you or if they come to see one of the other FHO doctors, that the continuity of care is there, that you'll be able to follow and track everything that's going on much simpler. Not having appointments on the same day, again, you have to leave spots open for your patients within the FHO model. Patients not aware of the after hours, putting up posters, giving out cards, putting up sheets of paper in the exam rooms and the waiting rooms. Everything you can do to educate the patients on what's available to them is very important. Some of your referral patterns as well. Who are you referring to? Any physicians that are providing psychotherapy or sports medicine that don't have the focused practice designation are going to eat away at your access bonus. So pay attention to who you're referring to. So what are we going to do about it? We're going to analyze the data. We're going to look at who needs to move from the FHO to the fee-for-service bucket. So we're just going to deroster them. You're still going to be their patient. They're still going to be your patient. You're just going to get paid a little bit differently for them. Retroactively deroster up to 6 months. In some cases, the ministry does go a little bit longer, but up to 6 months is the general rule of thumb. So getting back all that outside use that has been incurred during that time. Any visits that you've had during that time will get topped up to the full fee-for-service value as well. So it's very important to know what date to use when derostering. Again, daytime access issue, ensuring same-day appointments. Educating the staff as well. So not only are we educating the patients, but educating the staff to understand that we don't want patients going to the walk-in clinic, and why don't we want patients? So they can tell the patients on the phone, no, please come to see your doctor or one of the other FHO doctors at a given time, or tell them about the walk-in after hours. Educating the patients again, what it means to be in the FHO, and being aware of some of the red flag codes. So what are the red flag codes? General assessments, home visits is a big one now with so many services that do provide home visits. The focused practice designation, so just to name a few, sports medicine, allergy, pain management, sleep medicine, addiction medicine. all that kind of stuff. Palliative care codes, psychotherapy, all these codes are very high dollar value, and they eat away at your access bonus very, very quickly. So it's important to know who you're referring to and picking up on these red flag codes. The impact of derostering. So as I said, it's really an administrative relationship that changes with your patient. So they don't have to know necessarily. It really makes no difference to them. You're just getting paid differently when you see the patient. So instead of having your capitation, you're going to get paid fee-for-service every time you see the patient. So outside use reporting. So a little bit about what we do is we provide a proprietary analysis to show you what your patients are doing. We look at the cost-benefit analysis. We input all the data from your ministry outside use reports into our system that provides us with the analysis to say, what are the patterns and trends of your patients? What days of the week are they going? What codes are being utilized outside of the clinic? And what is the dollar value associated with those codes? When does it make financial sense to deroster a patient? If you're still earning money from them, we want to keep them on. If you're not earning any money, so the outside use exceeds what your capitation payments are, we want to deroster them and see them fee-for-service. So as I said, here's a couple snippets from our outside use management analysis. On the left, you can see what codes are being utilized, so we provide a pie graph to see that. And on the right there, you can see what days of the week are the highest for outside use, how many services are being utilized on all these days. Very important information. Here you can see the cost-benefit analysis. Again, how much capitation are you getting? How much outside use are you getting? Are they incurring? And what is the dollar value difference? All the way on the right there, you can see the return column. Anything greater than 100% means you're not earning anything from having them on the roster, and we want to deroster them. How many codes are being utilized outside? How many services are being utilized outside of the clinic? Over how many months? What's the earliest date of outside use? We've now added the most recent date of outside use as well. So if it's continuing, we'll see that. And what top services are being utilized for that patient? So you can have that discussion with them and say, Mrs. Smith, I know you've been having a home service come see you. Are you not able to come see me anymore? Would you like that? Maybe you provide the home service so you can offer that to them, or whatever the case may be. So a little bit about preventive care now. 12,800 available to you as we approach the end of the fiscal year. In April, you guys will receive a report to show you what patients have been provided the service in all these categories. So it's very important that you bill tracking codes, exclusion codes, to know what patients have had the service, what patients have not. Then you can track that within your system and double check on the report that the ministry sends you. Very important to look at those who haven't had the service to make sure that they in fact have not, because oftentimes tracking codes or billing codes don't get billed properly, or they get rejected, you don't realize, and then the service isn't tracked. So very important to double check those. And here's just a quick snippet of what that report is going to look like. It still comes by paper in a big brown envelope, and you'll receive it probably mid-next month, middle of April or so, and you'll be able to provide that those billing codes, and you have obviously up until the end of September to bill that. But the sooner you do it, the better off you'll be. So a little bit about special premiums. About 37,000 available across 8 categories. These are the 8 categories. For those that have recently switched from the FIG, you'll notice hospital, office procedures, and prenatal are new. They were not provided in the FIG model, but they are in the FHO. So all 8 of these categories are available. Now, we're not saying to go out and start providing service in all these categories, but make sure that you're getting paid if you are providing. If you have prenatals, make sure you're billing the P003 and 4. If you have serious mental illness patients, bipolar or schizophrenic, make sure you're billing the Q codes. Same thing for home visits. All the home visit codes that you should be billing, make sure. If you're providing office procedures, make sure of that as well. All of these services have their own codes. Very important to make sure, especially as we come close to the end of the fiscal year now, that all these bonuses have been paid. So some of the key takeaways for today, ensuring that patients being seen in the FHO are actually on the physician's roster. So again, unless you're purposely derostering them, make sure that your roster, according to your EMR and according to your Ministry of Health, align. Remember to submit your Q codes when rostering a patient. That's the only way you're going to get a patient onto your roster. Preventive care bonuses, submitting the tracking and exclusion codes, very important. It makes your life much easier when the time comes in April for you to start calculating your percentages. Outside use is a daytime access issue, so make sure that you're providing enough open spots. Walk-in clinics are happy to see your patients, but we want them to come see you. Derostering retroactively, again, make sure that you're making an informed decision of when to deroster a patient. Look at the cost-benefit analysis of if you're earning any money from having them on the roster or not, and then deroster accordingly. And most importantly, we are here to help. We answer questions day in and day out, and if you have a question, chances are we've heard it before, so please reach out. All of our services are available. We provide hands-on, face-to-face interaction both with physicians and their staff. We help optimize all areas of the practice to ensure it's very effectively run, and we're happy to start working with you as well. So with that, here is my contact details. You can send me an email, you can give me a phone call, and I'd be very happy to speak with each one of you to further discuss any questions you have with regards to your particular practice, whether it's individual or group, and help you get set on the right way to ensure an optimized practice. So thank you very much for joining me today. I hope everyone has a wonderful day, and I look forward to speaking with all of you very soon. Thank you.